Welcome. In this session we are going to discuss intermediate uveitis. And in intermediate uveitis, the predominant site of intraocular inflammation is the vitreous cavity and the vitreous base adjacent to the pars plana. Intermediate uveitis contributes to 1 to 10% of all uveitis, and it has been found that intermediate uveitis has a bimodal age distribution with one peak between 5 and 15 years of age and another peak between 20 and 40 years of age. Typically, intermediate uveitis has an insidious onset and a slowly progressive course. Usually, it is a bilateral disease, although it may be asymmetric. The main complaint of patients with intermediate uveitis are floaters, and there may be mild to moderate blurring of vision. Typically, there is no conjunctival congestion, but children with intermediate uveitis may present with redness, photophobia, and discomfort. Signs include vitreous cells. So in this picture we can see the vitreous cells behind the crystalline lens, vitreous haze, snowballs which are aggregates of vitreous cells within the vitreous cavity and usually lie in the inferior aspect of the vitreous cavity, and presence of exudates over pars plana is called snowbanking, and this also occurs predominantly in the inferior quadrant. Peripheral periphlebitis is another feature of intermediate uveitis, and we here see the perivascular infiltration along with snowballs. And in intermediate uveitis, anterior chamber cells may be present, but they are much less than cells in the vitreous cavity, and they are said to have been spilled over from the vitreous cavity. Most intermediate uveitis patients do not have any cause, and then we call it pars planitis if there is an associated snowbanking. Non-infectious causes include sarcoidosis, important to remember, and multiple sclerosis. Infectious causes of intermediate uveitis include tuberculosis, syphilis, cat scratch disease, HTLV1, and Lyme's disease. An intermediate uveitis presentation demands routine uveitis testing. In addition, we can assess the serum angiotensin converting enzyme and lysozyme levels. If we suspect sarcoidosis, fluorescein angiography may show us macular edema, disc leakage, peripheral periphlebitis. Here we see a fluorescein angiogram showing peripheral periphlebitis, and the peripheral periphlebitis can lead to peripheral retinal ischemia followed by neovascularization, which may also be picked up by fluorescein angiography. Macular edema can also be detected with an OCT, and B-scan and ultrasound biomicroscope can become useful in patients with small pupils and dense cataracts because they may pick up vitritis and pars plana exudates in these patients. Like any uveitis process, ruling out or treating an associated infectious process is the first paradigm in the treatment of intermediate uveitis, and mild vitritis with good vision and no CME requires only observation. So there will be intermediate uveitis patients whom we need not treat, and these are the patients having vitreous cells but with good vision and no cystoid macular edema. Periocular steroids such as transeptal or posterior subtenon is the first line of therapy, particularly in unilateral presentations, and they need to be repeated every 3 to 4 weeks. Intravitreal steroids are indicated particularly for macular edema, and the site of intravitreal injection should be away from the location of peripheral inflammatory involvement of the intermediate uveitis process. Systemic steroids is indicated in bilateral presentation or inadequate response to periocular steroids. Non-biologic IMTs should be administered in recalcitrant situations, and azathioprine, methotrexate, mycophenolate, and cyclosporin all have been reported to be efficacious in intermediate uveitis. TNF inhibitors like adalimumab and infliximab are also an option in recalcitrant situations. However, before administration of TNF inhibitors, an MRI of brain is advocated so that associated multiple sclerosis is ruled out, as multiple sclerosis is known to be worsened by TNF inhibitor therapy. 10% of intermediate uveitis have a self-limiting course. 30% have remissions and exacerbation. However, the majority of the patients, 60%, have a prolonged course without remissions. If you are able to control the inflammation and the associated macular edema, long-term visual prognosis is good. Complications of intermediate uveitis include macular edema, which is the major cause of loss of vision in intermediate uveitis, cataract, glaucoma, peripheral retinal ischemia with neovascularization of either the retina and or the optic disc. This may lead to vitreous hemorrhage, which is a more common presentation in children. Retinal detachment can occur and it's usually exudative or tractional, but rarely it can also be rhegmatogenous. Epiretinal membrane, vitreous opacification and band keratopathy are other complications of intermediate uveitis. Macular edema, as has been mentioned, is treated with periocular or intravitreal steroids, and vitrectomy can be indicated if the macular edema is not responsive to periocular or intravitreal steroids, to remove posterior hyaloid adherent to the macula, if any. Cataract surgery in intermediate uveitis may be complicated by recurrent retrolental opacification despite capsulotomy. Peripheral ischemia and retinal neovascularization can be treated by laser photocoagulation and or intravitreal anti-VEGF injections, and vitrectomy may be required for vitreous hemorrhage, tractional and or rhegmatogenous retinal detachment, epiretinal membranes or vitreous opacification. And all surgical procedures should be done after institution of appropriate and effective anti-inflammatory treatment. Differential diagnosis of intermediate uveitis include primary intraocular lymphoma, in which we find vitreous cells without other features in an elderly patient. Ocular toxocariasis may present with a peripheral granuloma and can be mistaken for a snowbank. There are certain inherited retinal disorders with peripheral retinal involvement simulating snowbanks, and Coats disease can also mimic intermediate uveitis. Multiple sclerosis is closely associated with intermediate uveitis, and uveitis is 10 times more common in multiple sclerosis than in general population. And intermediate uveitis, usually bilateral, is most common in multiple sclerosis, and the intermediate uveitis in multiple sclerosis is usually low grade in intensity and may be associated with a mild macular edema and periphlebitis. Diagnosis of uveitis may precede diagnosis of multiple sclerosis by years, and severity of the uveitis does not correlate with severity of optic neuritis or other neurological involvements in multiple sclerosis. Interferon, which is a recommended therapeutic modality for multiple sclerosis, has also been shown to improve inflammation and macular edema of intermediate uveitis, and fingolimod therapy for multiple sclerosis may exacerbate macular edema, and TNF inhibitor therapy for the intermediate uveitis may exacerbate multiple sclerosis. Thank you for listening.